Hi everyone, myself Anita, lecturer, Department of Child Health Nursing at Rajiv Gandhi Group of Institutions. Today we are going to discuss on the topic that is apnea of prematurity, which is very important topic related to respiratory system. Before starting the topic, let's have a look that we are going to discuss today. So, first we will discuss about introduction, then definition, types, classifications, incidence, potential causes, clinical manifestations, pathophysiology, diagnosis, treatment, management, and prevention. Now, let's start with introduction. Apnea is more common in preterm infants, which occurs between second to fifth day of life due to immaturity of developing brain. As we know that in preterm infants, the part of central nervous system, brain and spinal cord that controls breathing is not yet mature enough for non-stop breathing. This causes large bursts of breath followed by periods of shallow breathing or stop breathings. So, after the birth of premature baby, apnea can occur second to fifth day of life due to immaturity of developing brain. Definition: apnea may be defined as cessation of respiration for longer than 20 seconds over any duration if accompanied by sinus and sinus bradycardia. That means apnea is holding breath or end of breath longer than 20 seconds. Shorter event less than 20 seconds can also be called apnea if present with sinuses and sinus bradycardia. That is, if SpO2 less than 80 to 85% and heart rate less than 80 beats per minute is present in the patient, that is known as the apnea. Now, let's talk about types of apnea. There are three types of apnea: central apnea, obstructive apnea, and mixed apnea. First, let's discuss about what is central apnea. Central apnea is caused by decreased central nervous system stimuli to respiratory muscles. In this apnea, both airflow and chest wall motions are absent. Or we can say that the baby do not have both respiratory effort and airflow. Gestational age is the most important determinant of respiratory control. So, the frequency of apnea occurs is related to gestational age. Due to the prematurity, there is not mature medullary respiratory control center. The specific pathophysiology is not understood completely, but it is occurred because of pathological causes like sepsis, metabolic problem, which is hypoglycemia, hypocalcemia, temperature instability, respiratory distress, anemia, and polycythemia. And second one is obstructive apnea. So, by the heading we can understand what is obstructive apnea. It is obstruction, or it is due to the obstruction or blockage of the airway due to the saturation, improper positioning like hyperflexed neck or hyperextended neck of baby. It is characterized by absence of airflow but persistent chest wall motions. That means the baby has its respiratory effort, but there will not be airflow presence in the chest. And the third last one is mixed apnea. It is the most idiopathic apnea in preterm neonates. In prematurity, it mainly starts as either obstructive or central, and then involves elements of both and become mixed in nature. Usually, obstructive apnea precedes central apnea. Short episodes of apnea are usually central, whereas prolonged ones are often mixed. This apnea depends on the sleep state. Its frequency increases during active sleep. So, there will be rapid eye movement presence in the patient. Next one is Classification of apnea. Apnea is classified into two categories, primary apnea and secondary apnea. So, what is primary apnea? It is the first stage of temporary respiratory seizure stop. Primary apnea is occurred due to the deprivation of oxygen, produced by the infant suffering from a short period of rapid breathing. If the asphyxia continues, then the respiratory movement seizures stop. The heart rate begins to fall. Neuromuscular tone gradually diminishes. It can be corrected by giving stimulation measures, such as drying or mild slapping of its feet, and sometimes may need of oxygen to establish breathing pattern. Next one is secondary apnea. If the primary apnea is not corrected, asphyxia continues. The infant develops deep gasping respiration. The heart rate continues to fall. Blood pressure also falls and becomes nearly flaccid. The respiration becomes weaker and weaker until the infant takes the last gasps and enters a period of secondary apnea. It cannot be corrected by stimulations. Infant need to be given positive pressure ventilation or may need to be ventilated for some hours or days for correction. If it is not corrected, the infant may lead to death. Incidence of apnea of prematurity is it occurs in at least 85% of infants who are born before 34 weeks of gestation. Now, potential causes of neonatal apnea and bradycardia. So, the factors that can cause apnea in neonate in central nervous systems are like drugs, like midazolam, magnesium sulfate, phenobarbital, which are used for sedations and to control seizures, may lead to apnea. Another one is intraventricular hemorrhage. So, you can see in the picture it is indicated that in one part there is presence of hemorrhage. So if there is presence of hemorrhage, then it may lead to neonatal apnea. Others are seizures, hypoxic injury, neuromuscular disorders. So other factors which may lead to neonatal apnea in central nervous systems are like Lead syndrome, brain stem infections like meningitis, and spinal cord injury after general anesthesia. So, these are the causes which may lead to apnea in the prematurity. Respiratory system. If there is any alteration related to respiratory system, then it can cause apnea. Factors that can cause apnea due to respiratory systems are pneumonia, obstructive airway lesion, upper airway collapse. The picture which shows the difference between the normal and abnormal lungs. In the right side, you can see clearly lungs which is normal, but in the left side picture, there is upper airway collapse in the right side of the lungs, due to which the lungs fails to function and cause apnea. Next is extreme prematurity, in which the lungs are not developed well, due to which the baby cannot respirate properly and the apnea may develop. Others are phrenic nerve paralysis, hypoxia, laryngeal reflex, and pneumothorax. So these are the causative factors that can lead to apnea due to the respiratory system. Infections that may cause apnea are sepsis, meningitis, that may be fungal or bacterial, respiratory syncytial virus, and pertussis. In gastrointestinal system that may lead to apnea are oral feeding, bowel movement, necrotizing, enterocolitis, and intestinal perfusion. So, during oral feeding, if the baby get aspiration, so due to aspiration, the feed may goes into the lungs and may have difficult in breathing at the same time and may lead to apnea. Or later, due to the aspiration, there may be chances to have aspiration pneumonia which damages the lungs and may be chances to have difficult in breathing and may lead to apnea. Other is bowel movement. So if there is an abnormal bowel movement, that may lead to aspiration, and may lead to apnea. Necrotizing, enterocolitis, and intestinal perfusions are also the causative factor which may lead to apnea in baby. In metabolic system that may lead to apnea are due to the decreased glucose level, decreased calcium level, increased or decreased sodium level, increased amino level, increased organic acid, increased ambient temperature, and hypothermia. So these are the causative factors which can cause the apnea in the baby. In cardiovascular systems that may can lead to apnea are hypotension, hypertension, heart failure, anemia, hypovolemia, and vagal tone. Other factors that may lead to apnea are immaturity of respiratory center and sleep state. So, due to the immaturity of the respiratory center, there will not be respiration control over the respiratory system and may cause apnea. Other is sleep state. So, during sleep state, due to the improper position of the baby, can obstruct the airway and cause the apnea. We can take the example that if the baby has hyperextended neck or hyperflexed neck, due to which there may be chances to have obstruction in the airway and may have difficulty in breathing, or the air may not be able to pass in the lungs and cause apnea in the baby. Clinical manifestations. So let's talk about the clinical manifestation. Common symptoms include period of absence breathing for 20 seconds or more. Symptoms begin during in the first week of the life or later. More serious form of apnea. There will be longer period of absence of breathing, bradycardia. Apnea, blue coloring. Symptoms begin right after birth or after the second weeks. So these are the signs and symptoms which are present due to the apnea. For diagnosing the apnea, what things should be carried out are history collection. So history collection should be done from the parents of the baby. After that, physical examination and investigations. So what are the investigations that should be carried out are blood glucose, hematocrit, electrolytes, and septic screen, blood culture, EVG, chest X-ray, abdominal X-ray, USG head. Other investigations depend on the history of the physical examination. So these are the things that should be done for the diagnosis of the apnea. Now, let's discuss about the pathophysiology of apnea of prematurity. Studying in the left side of the figure, the fetal and neonatal transition and exposure to excessive oxygen can lead to postnatal hypoxia, which causes decreased peripheral chemosensitivity and can cause prolonged apneic event. On the right side of the figure, decreased respiratory drive and recurrent apnea causes postnatal intermittent hypoxia and lead to increase in peripheral chemosensitivity. Increased sensitivity can trigger hyperventilation, decreasing carbon dioxide concentration, and lead to apnea. So, finally, there will be respiratory instability in the baby. Let's talk about the treatment which should be carried out if the baby is having apnea. So, general measures. What should be done for the general measures are we have to maintain the temperature, airway breathing, and circulation. We should not do vigorous suctioning of the oropharynx. We have to avoid oral feeding for at least 24 hours if the baby is having apnea. We have to adjust environmental temperature. We have to maintain of underlying causes like sepsis, anemia, hypoglycemia, and respiratory distress syndromes. Specific measures that should be carried out for treating apnea of prematurity are by using the drugs. The drugs like immunophilin, theophylline, caffeine, and doxaparam are used to treat apnea of prematurity. Along with that, sometimes blood transfusion is also necessary because apnea found to be associated with lower hematocrit as well. If we transfuse the blood, it will increase in respiratory drive, resulting from increased O2 carrying capacity and increased tissue oxygenation. Moving towards emergency treatment. So, the neonates should be checked for bradycardia, cyanosis, and airway obstruction. The neck should be positioned slight extended and oropharynx should be gently suctioned. Tactile stimulation should be given as most of apneic respond to the tactile stimulation. Provide oxygen if patient is hypoxia via hoodbox or nasal cannula. Saturation level of baby should be maintained at least 92 to 95%. After tactile stimulation, also, if apnea will still remain in the newborn, then ventilation with bag and mask using 100% oxygen should be done. And if bag and mask ventilation fails to initiate spontaneous breathing in the newborn, then infant should manage with positive pressure ventilation. One of the most important medicine that is used for treatment of apnea of prematurity is caffeine. Caffeine works by blocking adenosine receptor. It helps to treat prematurity of apnea by increasing minute ventilation, improve CO2 sensitivity, decrease periodic breathing, decrease hypoxic depression, improve diaphragmatic contractility, shorter duration of mechanical ventilation. The earlier treatment is indicated. Caffeine is recommended for all infants born less than 28 weeks as well as 29 to 32 weeks depending on the clinical course. Its loading dose is 20 mg per kg followed by maintenance dose is 10 mg per kg per day. Trial of caffeine after apnea free period of 5 to 7 days or 33 to 34 weeks. Correct gestational age is often recommended. Caffeine side effects are tachycardia, cardiac dysrhythmia, seizure, feeding intolerance, and decreased metabolic demand. Discharge consideration. During plan of discharge, we have to observe that the baby he or she should be free from any complication like difficult in breathing, cyanosis, tachycardia, or bradycardia. We have to observe the condition of the baby properly after the discontinue of caffeine therapy. We have to check the activities of the baby and we have to observe feeding ability of the baby. So, if baby is free from all the complications and baby is having good feeding ability and the activity of the baby is good, then we can move towards the discharge plan and we can discharge the baby from the hospital. Preventive measures that should be carried out for the prevention of apnea of prematurity are during the pregnancy, the mother has to follow up for antenatal checkup and find out if there is any complication in the mother or fetal. If complication found, then it should be treated to correct it. Avoid alcohol and illicit drugs during pregnancy. That means the mother should not take any kinds of alcohol or drugs that may hamper the baby and may occur apnea after the birth. Avoid smoke during pregnancy and after birth. Maintain the position of the baby. Maintain the position of the baby during sleep because due to the sleep there may be sleep apnea if the position is not maintained properly. encourage breastfeeding, and avoid cold and overheating, because if there is overheating and if there is cold, extreme cold, then it may lead to apnea in the baby. Preventive measures. That hope this topic which we discussed today was useful for you all. Thank you.